Okay, we're going to kind of late getting started for the next session, so we want to try to stay on time here. We can get everybody back in the room. We're going to do a drawing for one of the door prizes today. If you haven't put your name in there, and go ahead and do that. But Dr. Brian is going to draw for the first door prize.
Catherine Medley, nephrology. Is that correct?
Lacey will bring it to you. You don't have to come all the way up here. So it's my pleasure to introduce the next speaker. I've known of Brian for many, many years. Got to know him a little bit over the past few years. He is very well known at SVU, and talking about he has a passion for veins. So we put him in the best role here, but Brian dabbles in a lot of things, but excellent at talking about vein disease and the critical role of vascular ultrasound in the workup of vein disease. Really glad to have him here today. He told me to keep it short. I could go on for another 10 minutes about his accomplishments.
Fine. Can everybody hear me? Okay. So first of all, I want to thank Tracy and Dr. Lusar for inviting me. I've been following Vic for a while, so I'm very impressed with the conference. So my background, I've did all kinds of stuff as far as vascular-wise, and started doing veins in 1999. The first ones we did were in the hospital. They took 2.5 hours. It was the old venous catheter. It had prongs, and it wasn't really until about 2009 that I dove into veins really hard. 2006, 2007, I guess. And I do have conflicts. I talked for Phillips. I teach a master course. I'm actually flying out tonight to go there. And a partner at Truffles Vein Specialists. We're a center of excellence for Medtronic. But the role of the sonographer, really, we are an extension of the doctors. And so I always use this because sometimes the providers, they can see, on some patients, you can see everything. You can see the patterns. You can see the veins wrapping around. You know where they're going. And on others, you can't. And so our role, I use this analogy of investment property. I didn't buy this house, but I did buy a house in Manchester, Georgia for $25,000, sight unseen, because it looked good on the outside. And when I got inside, it was a mess. But our role is to assess and give the idea of what's going on inside, okay? Because even though some of my people were like, that house looks like it has roaches, I was like, I didn't think so. But the ultrasound really we provide a complete picture that even the best clinical patient or provider cannot see what we see, and we are an extension of them. So we need to know if there's anatomical variants, the anatomy, which veins they are, name them correctly, where they go to, evidence of dysfunction, connections through intersaphenous veins, perforators, varicosities. At least at our center, and I've got 5 vein centers in south of Atlanta, the sonographers play the pivotal role. We work hand in hand with our providers, and we are entrusted to go to them and say, hey, this patient has this, VenaSeal is not a good candidate for this reason, and so forth. So there's a lot of focus on what the sonographer does. The biggest thing I would tell you, the biggest critical component if you're going to be a good sonographer is you have to think clinically. We are not just picture takers. We are an extension of the MD. We have to understand vein disease as well as the physicians do. I know that's like probably bastardized talking to say that, But the more we know, the better we help them. And the thing is, it becomes a dialogue between them and us. So when I get in there, I ask the patient, tell me about your legs. What kind of procedures have you had before? Have you had any surgeries? And the thing is, the patient's going to think you're just being nice, when you ask them how many kids they have, how many pregnancies, what do they do for a living. But really, I use that to glean information. So, I'm an adult man. It's odd for me to walk in the ultrasound room and go, hey, do you have pain during intercourse? Okay, it's just a weird question. However, if I talk to them and they say they've had 3 kids and they're 18, 13, and 12, and they play sports, and then I get down the road 15 minutes later and I see evidence of pelvic dysfunction, it opens up a pathway for me to say, hey, during your 2nd or 3rd pregnancy, did you ever have vulvar varicosities or varicosities in that area? And the patients don't think it's a weird thing because we've created some rapport. I understand she has kids. I understand her history. And so those are things that, as a previous speaker talked, a lot of times the physicians don't have an hour and 20 minutes with a patient. And so they'll tell you information you need. So if you're going to you cannot be a great sonographer without thinking clinically. You're an extension of the MD. That's the thing. The other thing I'd say is you have to evaluate the deep system. And this probably changed my whole thought process. Once I started focusing on deep venous, it changed my philosophy on my thought process of how venous disease starts and how it ends. So the first thing we do is we evaluate the common femoral flow. We have their hands by their side. We don't want, most patients get in there and put their arm behind their head. That elevates the diaphragm. It changes the pressure intra-abdominally, takes flow out of the legs. We usually have them reverse Trendelenburg. We don't do that, the deep venous while they're standing. And then to optimize the waveform, we also slow down the sweep speed. I've been talking about that since I think 2016. It really does bring out the pathology a lot. This is 16 seconds worth of venous, so it's not just as simple as the patient was holding their breath. Now, the other thing is I'll let it run. Sometimes I let it run for 45 seconds or a minute just because patients act goofy. When they hear it, they can hear their breathing and they'll start breathing irregularly. The other thing that you have to be conscious of is, are they wearing Spanx or are they wearing control top underwear? I know that's kind of a weird thing, but it's a question you have to ask. Even guys, I told a patient recently, I was like, hey man, for Christmas, you need to ask for some underwear because you haven't got, they were so tight. They were like, you could barely get the washcloth underneath. And so I had to go get him, because it was affecting the waveform abnormally, I actually had to go get him a pair of blue shorts and had him take off his underwear. It's a rare case, but it does happen. So you want to evaluate for phasicity and spontaneity. And this is so dang easy, but I can tell you, nobody does it. Most people turn on the Doppler. Usually it's after they've done compression of the whole leg. They go back up to do the Doppler. They turn on the Doppler. It runs for like a second and a half, and they're either doing a valsalve or augmenting. This is one of the transformative things that we've done in our practice, and then we started this 8 years ago. We diagnosed a lot of deep venous dysfunction. I've got a case study at the end where we didn't follow that policy or that protocol, and it caused a delay in diagnosis. So deep venous protocol, again, we assess for proximal disease. That's what the Doppler waveform is for in the groin. If you're IAC accredited, it's not for a compression, it's to evaluate for inflow disease. Not all the time is it continuous. Sometimes it can just be abnormal. This is an abnormal. This patient had an 85% iliac lesion up above. The other thing I'd note on this picture is look at the color flow. I usually take two, and we take velocities in the common femoral. I usually take two. One would be further back, right before the junction. You can see that the color flow, it's very dark blue, it's nice and smooth, and you can see the acceleration through the color change in the front. I will say the most common compression that's missed is the compression by the inguinal ligament in the groin. We have found so many patients with inguinal hernias that are causing compression syndrome. They don't need stents, but we send to general surgery. They repair the hernia, and a lot of the deep venous things that we're seeing dissipate. The other thing I would talk about, I did a hands-on session for a big hospital in the Ohio area, and the thing is they very rarely saw deep venous dysfunction on their reflux studies. And I'm like, that doesn't make sense to me. You should almost always see close to a second of reflux in the deep system if you're gonna have saphenous vein reflux. It just doesn't make sense. If the deep venous is totally competent, why is the pressure being exerted on the superficial? And what I found is most people just put the cursor willy-nilly in the middle of the vein, okay? So this is not an optimal picture. As you can see, my Doppler is kind of broken up there, and that's because I need to move it over about a millimeter this way, okay, where that jet is going. And a lot of times in the common femoral, you'll have a jet below that valve that's going around the posterior side. You have to evaluate before you put the cursor in. So how does that change this setting? This person had 2.84 seconds, okay? If I don't look at the Doppler ahead of time and I don't see this abnormal waveform and I don't accurately get the deep venous, all of a sudden my doctor on the other side, when he's looking at the report and looking at my images, he has no idea that I missed it. There's no way for him to be able to. You're the key player there. Okay? The other thing we do is we evaluate the deep system below the junction. So my philosophy is this. You have deep venous reflux in the common femoral, maybe it's a second and a half, and then you have junctional reflux going out the axial veins, the anterior accessory or great saphenous. That deep venous dysfunction should not carry through the leg. So when we see reflux below the junction in the deep system, after that makes us think, okay, we're starting to think, is there deep venous dysfunction in this patient? Okay, so we evaluate, same thing with popliteal, femorals, common femorals, and we do evaluate gastrocnemius and tibial when it's visualized, especially if you see a patient that has very complex gastroc perforators, large varicosities. The gastrocnemius veins themselves often have significant reflux in those. Next, we look at variants. Not all variants are bad, some are good, but we want to know. I have one of my sonographers, Chris. She started with me a little bit over a year ago, and she struggled at first, and she's one of my better sonographers now. But she focused in on anatomy, and we started seeing a lot more of just variants that we've focused as a group. I've got 16 sonographers in my thing, and it's made a big difference. So the other question I said is, if you don't see it, if you're in a big group, like, somebody's going to find it, right? Is it going to be your competitor that finds it, or is it going to be another sonographer in your thing? And I always say there's always that extra sonographer who finds everything. It's me. And so, but I like it when there's more than just me doing it. I love it when somebody, especially young sonographers, come to me and they go, hey, this patient has a low bifurcating tibial, or this patient has a bitruncal femoral vein. That means that they're paying attention to what they're doing. They're just not going through the motions. So we're going to talk about some variants. So like this is a very simple one. It's a high bifurcation of a common iliac arteries. So it's a high bifurcation, and what you have is the femoral, superficial femoral artery and profundifemoral are actually crisscrossing over the femoral. So it's causing a compression at that level. Now, again, there's no way for them to be able to know that, and sometimes they have to stent down through that, and not all the times. Other anatomicals of femorals and popliteals, for as long as I've been scanning, you see so many duplicate femoral veins, you just think nothing of it, right? Including myself, until about 4 or 5 years ago. Now I pay attention. I look at their size mainly. So when you see small femoral veins, and you guys have all kind of like, oh, this patient's got really small, like that should be your telltale sign to look at the profunda. Okay, so next time you're scanning, you see duplicate femoral veins, they're very small, you're doing your compressions, I want you to focus at the profunda. So that's a characteristic of the bitruncal femoral vein. And there can be all kinds of variations as they go down. I love this next slide because this slide, I'm going to walk a little bit because there's some, I don't know if I have a pointer on here or not. Is there a pointer? Yeah. So there's a lot of anatomy going on. This is the femoral vein, basically a bitruncal femoral vein. We're talking about it develops from the bottom. So you have the regular femoral vein here, and you have the pudendal vein or deep femoral vein that comes off the popliteal. A lot of times it's above the knee, so it's a little hidden. It's not right here. It's a little higher up, okay? And it'll go up, and it connects, and it becomes the dominant vein, and it's characterized by small femoral veins medially. The first time I ever saw one, I was in a Facebook group with May-Thurner syndrome, and this guy was like, all these people are complaining of leg swelling. My radiology report says that my femoral vein is occluded from proximal thigh to distal thigh, but I have no swelling, and nobody can tell me why. And he flew up from Florida. I scanned him, and he had this huge profunda femoral that was feeding, going all the way around. I'm sorry, I'm going to go back. Other thing that you notice about this picture is off the profunda, you have these connections and you have an SSV extension. You see that a lot as well. And so you look how complex this is. You have these veins coming over medially. You have the profunda femoral also connected to an SSV extension. And so if you can catch all that as a sonographer, there's a high rate of patients with this anatomy that have proximal disease. Okay? We've talked about writing a paper on it because we have some data, but we're just busy. It's hard to read data when you're like trying to scramble to find. I got a call this morning like, hey, somebody called in, their kid's got RSV. We've got a whole set of ablations. We don't have anybody to be there. So, I mean, it's difficult when you're busy, but every time I see it, we almost always scan up and see significant iliac vein compression. So bitruncal femoral vein, again, this is sometimes not all I have like 23 ultrasound machines. Not all of them have panoramic. So I'll take pictures sequentially, or I'll take a long video. This is not the best panoramic. I will say that is a hard panoramic image to get, but when you can get it and show it, it's great. The other thing I was going to talk, and Chris was one of the first people to see this, is basically absence of posterior tibial veins. And, it's funny because people will just scan and they'll just go like, well, I don't see them, but there's not a clot, What you'll find a lot of times in 1 to 5% of case, you'll have a low-lying arterial that comes off. So the posterior tibial will come off at the distal ankle, and it's just a low bifurcation. Well, why does that matter? Well, I don't know if you should be doing Varithene on somebody that on the lower leg, all they have is perineal veins. They often don't have a lot of the tibial perforators, and so you should even question whether you're doing an ablation. It's something that we've noticed. This was a patient that, PTs right at the medial malleolus coming off the perineal. This is the common femoral before, and then after they had a GSV ablation. The deal is we caught it, and I just like being honest. Listen, we're not all perfect. I make mistakes. We all make mistakes, but we don't do it on purpose. This person caught it. It's in the paragraph of the final. Like, nobody reads the paragraph. Like, nobody reads the paragraph, right? They look at the image and they look at the conclusion. Like, I doubt your doctor is going through. And a lot of times, I hate to say it, there's 76 minimum images on our bilateral reflux. Sometimes there's up to 120. Like, the doctor's going, going through it. And so it's important to highlight. So what we do in our reports is we usually put 4 stars, then the thing says, hey, look at this. And we need to do a better job of communicating that. Intergramellar vein. I love the intergramellar vein. Hey, it gets me lunch all the time. Bet your doc, if you know, unless they're in here. Okay, most docs don't know what the intergramellar vein is called. So what it courses right posterior. It's a median gastrocnemius vein. So you have lateral and medial gastrocnemius veins. This is the median gastrocnemius veins. It runs right under the SSV. A lot of times when they're very dilated, they become problematic. So this next slide, this is actually a panoramic. It doesn't look big on this screen, this picture. That was a big gastrocnemius vein. It's by itself, and it connects right into the SSV in the mid-calf. Okay? So why is that important? How many of y'all do vein treatment here? Anybody? I know this is an arterial conference. They asked me to speak to 4 people. I'm just joking. So Varithena, if you look at clinically in their IFU, they're not approved for SSV. They did not include the small saphenous in their thing. However, insurances approve small saphenous for Varithena all the time. We do not do Varithena in the small saphenous because of the intermedular perforating vein right in that mid-calf. You end up with thrombus gastrocnemius all the time. Now in Europe, this is again the source of reflux. The SSV is not involved. This is the perforator out of there, and so you have significant dilated mid and distal calf SSV, even though the proximal SSV oftentimes is very small in these patients, right? So you're not going to get coverage for ablations, but then you see this dysfunction. In Europe, they actually treat below the perforator into the muscle. We don't. I'd be curious to see what everybody's thoughts on that is. To me, if we ablated inside the muscle, we'd consider that a DVT on post-op. But we treat usually from the fascial line out. Pelvic involvement, I talked about it earlier. So one of the things we look for, of course, it's easy when they have varicosities in the groin or out of the P points, out of the perineum or labial veins or even up top. But one of the ones that's missed is the deep pudendal vein. We find that it comes into the common femoral from the posterior side, usually about a 0.5 centimeter caudal to the saphenous junction, but not always. But for us, it's a very good indicator that there's flow going back and forth between the pelvis and the leg. Other evidence of deep venous, so while you're doing the exam, if you find large perforators without a history of DVT, okay, that should be a red flag. And it's usually just saying there's more deep venous pressure in the calf, and instead of normal flow in the perforators is from the superficial to the deep. When you have deep coming out to the superficial, you got to wonder why. And especially without a history of DVT. With the history of DVT, that changes the whole ball game because they get post-phlebitic syndrome, you end up with deep venous reflux, and that makes sense why the pressure would be increased on the deep side. But if you find it in a non-thrombotic patient, it should point to deep venous dysfunction. Other things we've noticed, reflux time over 2.5 seconds, high velocity reflux. It's hard, we don't have a number for it. I would just say the one picture on the right is about 25 centimeters per second. The one on the left's 160. You'll know it when you see it. And you guys have all done it when you do a Valsalva and it's just like, just tumbling, aliasing. Again, that should tell you something. The other thing, ultrasound-wise, continuous flow or significantly reduced. These are obvious. It's easy. You just have to be intentional. Intramuscular varicosities, again, are dilated cilial sinus. So when you see intramuscular varicosities, your question should be why? Why would there be intramuscular varicosities? And it's because the deep venous pressure has nowhere to go, okay? And we're talking, when I say deep venous pressure, usually these patients have an outflow obstruction, iliac vein compression up above. To give an example, a visual of this, if you take a garden hose and you pinch it with your hand, there's 2 things that happen. The flow behind it slows and the pressure builds in the hose. And the same thing happens in the leg. Okay, when the pressure builds in the leg, the flow has to go somewhere. And so it goes out through the perforators and you see dilated veins and abnormalities. So this is an easy one. This was a patient that had recurrent DVT in the left leg. She was 110 pounds. Her right common femoral was like 9.5 millimeters, and her left was like 26. Okay, that's an obvious, she's got all kinds of valves there, and it's just dilated dysfunction. So when you see large veins in somebody with a low BMI, that kind of is an indicator. Okay, you can see how close the dermis of the skin is. I'll go over this side on this time. So the dermis of the skin is right here. I mean, and you also look at the dilated epigastric. So both of those things, this is a thigh GSV in somebody with a BMI under 20. She was like 32 years old. So her right GSV was 10.9 millimeters in her proximal thigh, and she had varicosities all on the right leg. The left leg, contralateral, and you need to use that to evaluate. Her GSV was like 4.5 or 5 millimeters on the left leg. She ended up having left-sided iliac, cross-pelvic collaterals, and her right side was engorged. Okay. Here's another example of a pudendal vein. They don't always flow this way, but basically with Valsalva, everything in the common femoral is draining down posteriorly. And other patients, like this next one, you'll see that the flow is actually coming from the pelvis up into the common femoral, okay? And usually you'll see this side to side with cross-pelvic collaterals. Other different variations, people having multiple things. These are all things that you can pick up or pass. Listen, for 15 years of my career, I'm old, I've been doing this almost 30 years. For 15 years of my career, I didn't see any of this stuff. I still thought I was a good sonographer, but I missed a lot. And it's not me missing it. It's us missing it. It's us. It's everybody. If you're an extension of the physician. Here's another pudendal vein going off the common femoral. Again, this patient's very thin. You can see how close the common femoral is, like within a centimeter of the surface of the skin. But look how big that connection is. On the opposite side, and I've only seen this a couple times in my career, is this connection coming off the common femoral and actually went down the whole posterior thigh and connected back into the pop. I've only seen that twice. And so basically, they're just circulating blood flow, going back and forth. Oop, sorry. Nope, I was correct. So, quick overview. If you want to take a picture, this is a good picture. Continuous flow. For identifying deep venous dysfunction, continuous flow in the common femoral, reduced phasicity or abnormal waveforms in the common. I could spend 30 minutes just talking about abnormal common femoral waveforms. I really could. Large perforators without a history of DVT. Large lateral varicosities. Patients that have extensive lateral veins. It's, again, increased pressure. The pressure has to go somewhere, so they end up dilating. All their lateral system is totally independent. Dilated common femoral or asymmetrical common femorals. We usually use 3 millimeter difference. So if the left side's 18 millimeters and the right side's 12, it's a big difference. Reflux in the common femoral, greater than 2.5 seconds. This one's very easy to do, and it's very, it has very good sensitivity. Deep vein reflux in more than 2 segments. So again, if they have without a history of DVT, okay, that's a huge indicator. But common femoral reflux, femoral reflux, Papa T reflux, all in the same leg, no history of DVT. It's evidence of deep venous dysfunction. GSV greater than 10 millimeters with a low BMI. It's easy, right? You see skinny man or woman, and they've got dilated superficial veins. You should think, okay, why? Intramuscular varicosities, intracompartmental varicosities. Intracompartmental, usually you'll see it in the SSV, and again, the intramedullary plays a part in this. And so when you're doing a scan inside the compartment, you'll have varicosities that are interconnected with the SSV and all these perforators from the gastrocs connecting. And then a large SFV, now it's different. If somebody's 380 pounds and they come in and they got a 12 millimeter GSV, SAFM junction, that's pretty, pretty typical. But if you see somebody smaller and they have this huge dilated, you have to ask yourself why. And usually these things pop itself. And then continuous flow in that SAFM junction. That's the one that I used to miss a lot because you're focused again on trying to find reflux instead of paying attention to what what's going on. So I think the other critical component on this is venous anatomy. So superficial system, this gets confusing for everybody because they keep on doing consensus. I wish that they could get consensus before they published consensus, because there's like 2 papers out that name things differently, and then I go back and I look at our insurance carriers and they're calling it still So we still call it an anterior accessory great AAGSV. Our biggest payer is Blue Cross Blue Shield, and that's what they use, okay? But there's new paper that was published in June, and they call it the ASV, okay? But if your insurance doesn't call it an ASV, it can cause confusion. So that becomes site-specific. You have to get with your pre-cert people. Same with the PAGSV, we call it that way. Okay, so you got to know your anatomy. So the anterior accessory great saphenous vein comes off, usually we say within 2 centimeters, 2.5 centimeters of the junction. It usually runs anterior, runs on top of the arteries, okay? So that's kind of the align sign, what they call. A lot of times it'll exit the fascia in the mid-calf and have branches, some that go back to the GSV, some that go and feed this lateral anterior plexus. Posterior accessory great saphenous is less common. So between the two of them, we see AAs all the time. We see PAs maybe 1 out of 10 patients. But usually when they do, they come off posteriorly. Oftentimes they'll have a branch. One will connect back to the GSV, and the other branch often goes into the buttocks or into the posterior. And then we talk about anterior circumflex veins. So to be all honesty, if we see an anterior circumflex, we don't call it that in practical. We just say there's a branch off the GSV in the mid-thigh, okay? But we do call it on the posterior circumflex. And the posterior circumflex, I think, causes the most confusion with reflex exams. And I'm going to go over hemodynamically why that is the case. So the posterior accessory comes off of the GSV. Usually it's further down. So usually it's in the proximal thigh and it courses back. If it's small, it'll just go to this lateral plexus and die out. That's no big deal. A lot of times that's the number one. Number two, you'll see it a little bit bigger and it will connect to an SSV extension. Okay? So there's people who do reflex in different positions. I'm not even going to go there. The one position I'll say I disagree with the most is sitting. Because when you sit on the side of the bed, you're compressing all that posterior thigh, so you're not getting the true hemodynamics in play there. So posterior circumflex often connects into the cranial extension, originates from the lateral plexus, and then you can have intersaphenous veins, and it can be what was typically called the vena Giacomini, where it's an SSV, extends all the way and connects to the GSV. But also, that's not the only intersaphenous vein there is. There's a lot of intersaphenous connections. So we call anything that connects between two systems an intersaphenous vein. If it's a varicosity that comes off the GSV and connects into the SSV in the mid-calf, we call it intersaphenous varicosity. What we're trying to tell the doc is to explain that there's possibly two sources or even three that are providing the reflux. Okay. Posterior anatomy. So I hate saying this, but sonographers tend to pay less attention to the posterior side. You know, they focus on the GSVs. There's a lot of patients that we see that have complex posterior, and they were told they didn't have reflux. They only treated the GSV somewhere else. And so 40% of the time there's an extension. The role of the intermedullary vein or perforator, it's usually right in the mid-calf. That's also called the gastrocnemius point. So the gastrocnemius point is usually right in the mid-calf. It's where a lot of the branches from the GSV wrap around. It's where a lot of varicosities will come and connect into the SSV. And then you also have the gastroc perforators on either side that often connect as well into the SSV or varicosities. The other thing, the paraarchilian and Bassi perforators, these are the perforators in the distal calf. So a lot of times people go in the SSV, they look at the SSV, it's very small, they just stop, follow it all the way down, especially if they have lateral varicosities off in their distal lateral ankle. A lot of times it can be coming out of one of these distal perforators near the ankle and feeding those around the foot. Here's just an example of an SSV extension. Okay, understand hemodynamics. So I talked about the posterior circumflex. I went a little crazy on this. So let's talk about this. What I see a lot of times is you'll have people that find reflux at the junction. They'll even get reflux in the proximal thigh, and then they don't get reflux in the mid or distal thigh, and then all of a sudden they have a ton of reflux at the knee or in the proximal calf and below in varicosities, right? And so a lot of people will say, well, the mid thigh was competent, but the role of the posterior circumflex, so you think about it. When you're augmenting right here and you're looking for reflux and it's going up and going out the back, you're not looking at it, right? So you get a false negative. And so there's this pressure gradient down below. So what I'm talking about is the release down here in the proximal calf. So you have a lot of pressure here, and you've got reflux up here, and in between you get this pressure gradient where when you augment up, some of it's going out the back, some is going down. If you have tributaries, it's going off. And so what you find is that that SSV extension often will carry that load from the front. So even when you're evaluating an SSV extension and you see a large posterior circumflex, augment from the medial side and you'll often get the reflux on the back side in the SSV extension. So here's an example. I usually do a whole case report. This patient has like 2 seconds of reflux at the junction, then like 600 in the proximal thigh, and then it goes to nothing, and then it's a lot in the calf, and then the SSV extension has 12.2 seconds of reflux. Oh, what happened? What'd I do? Oh, it's showing something different on here. Okay, that's fine. Saphenous review. So they're great small saphenous. You got accessory saphenous veins. They run anteriorly and posteriorly to the GSV. You have your circumflex saphenous. They cross anteriorly over or posteriorly under. Small saphenous has a cranial extension 40% of the time. Posterior circumflex is very common. Duplicate GSV, they both have to be in the fascia, okay? And you got to be careful. There's a lot of vein centers that will say, call that anterior accessory a duplicate GSV because Blue Cross doesn't cover it. No, you have to stick to your guns. The anatomy is the anatomy. If we do free veins all the time, okay? But don't compromise. The anatomy is the anatomy. Stay consistent. And then there's other anatomical variations, just simply described based on what you know. Okay, we already talked about the role. Perforators, again, superficial to the deep, normal venous flow. And then the SFG and SPJ are actually perforators. Okay, people don't think about it that way. I love this drawing because this is all the perforators. Do you need to know the names? I take the names off on purpose. You don't need to know the names. Listen, I can look at a patient. I can see that the varicosities are wrapping right around the knee. I'm going to look for that perforator around that 4.2, right, to see if it's there. In the lateral calf, like 3.3 is the one I see the most. It's on the lateral calf. You'll see varicosities come off the GSV. It'll wrap all the way around. They'll have like a perf here, perf there, and then it'll end right in that mid-calf. So that's the source. There's two sources, from the top, but also inside the muscle feeding out. And then measuring perfs, you want to measure at the fascial boundary. A lot of people, the other thing I find that people stop here. Like if you have a patient that their foot is covered with veins, you've got to scan the foot. There's a lot of foot perforators, a lot of them. And again, why would somebody have a bunch of dilated foot perforators? Deep venous dysfunction, okay? So think about your house. You're holding the garden hose. Where does all the pressure in the hose go? It goes back to the faucet, to the house, okay? Your distal point is your foot. It can't go anywhere else. So it gets to the bottom. A lot of these patients that have an outflow obstruction, like iliac vein, will complain of cold feet because they got just stagnant flow at the bottom of their legs, okay? So here's always survey before you document. You know, here's a patient that there's an anterior accessory, there's a true duplicate GSV, there was a posterior accessory that came off before. So I like to scan through and figure it out because there's nothing worse than going, oh, that's the G. You get halfway down, you're like, nope, that's not the G, that was a, you know. So scan first, figure out what you're doing, and then document. This is a big one, okay? This monitor is not working for some reason. I don't know what happened, but I broke it. So SSV into the gastrocnemius. So the gastrocnemius, in what percent? 30% of the time, they come off the popliteal, and then the SSV is actually connecting into the gastrocs before the popliteal. Well, you have to know that. And you can't measure from the SPJ when you're doing an ablation on this patient. You'll end up with thrombosed gastrocnemius. There's other times where the connection can be even further down. You have to know those things to prevent, and you have to flag it big time in the report, because in our practice, we got 16 sonographers. Just because I did the study doesn't mean I'm going to be involved and go, oh yeah, Jenny had this, be careful. No, it's got to be, we've got to put it on there. So we actually put it on the schedule, we flag it, put stars, careful attention, okay? So you got to verbally communicate it and written. So we go to the provider and say, hey, this patient has this anatomy. We need to be careful, make sure it's on the schedule. So, of course, you got to note GSV, if it exits the fascia entering, is it less than 1 centimeter deep? Does it exit the fascia? Or is there areas of scarring, aplasia, hyperplasia, tortuosity? Anything that would affect treatment needs to be in your report, okay? You just can't have numbers in a drawing. It happens from time to time. We had a patient that was scheduled for venous seal. The report looked beautiful. And the patient didn't draw the GSV out of the fascia. The nurse practitioner didn't know. It didn't say it. And so she ordered venous seal. We got in there, we're like, we're not doing venous seal on this patient. Okay? And so we just stopped. And I think we did a free ablation. We do that too. When it's our mistake, we just say, it's our mistake. You're here. You took off from work. We're going to take care of you. We'll bother the Medtronic rep to get us a new catheter for free or something. And you got to know where the varicosities are coming from. You got to find the source, okay? You got to know your measurements. We measure the GSV at the SAFM junction and just off the SAFM junction. That's the wording. In our EMR, our PAC system, we don't have just off the junction. So often it ends up being proximal thigh. But in the insurance documents, they'll say just off the junction. So literally, people will disqualify somebody with significant reflux and evidence of vein disease because they measured here and then moved down here to take the second measurement after it's reduced in size. So you just got to be conscientious. And your report should look like the patient's anatomy. Okay, this is Nicole, she's an awesome sonographer in my Noonan location. She does amazing reports. She draws beautiful connections. Okay, but that makes it easier for the second sonographer, after they've had ablations, they're going in to do Varithena. Like, they don't have to start from scratch. They've got a reference to be able to look at. It saves time. And so it's a detailed report. This is something we've also noticed. We've had about 4 of these happen. The first one happened on the same patient. So she had an SSV ablation on both of them, and she complained of pain. The person who did the post-op was like, everything looks beautiful, like but this patient was in pain. And I went in there and I was like, maybe there's something going on? Well, yeah, she had SSV arteries, okay? So, arteries associated with an SSV, if you do a thermal ablation, it's gonna hurt the hell out of them, okay? So, it's not that we don't treat it, we just are gonna treat it non-thermally, okay? You can do an injection of it, you can do something else, or but you need, again, there's no way a physician's gonna see that, okay? Most of us scan in long, right? You look at the SSV, you're scanning in long for reflux, you might have done compression, but you're not looking for this little bitty artery, but we've seen it more often than you would care. It's hard to find documentation of SSVs, but I remembered in Ulta, I had to go back to they actually have taken this out of the newest version of the Cagliati et al. Anatomy. But I went back to the original version, and it says saphenous compartment contains the saphenous veins, accompanying arteries, and nerves. So, okay, you got to know your insurance requirements. Okay, it does no good for your marketing team to do all the work. The patient comes in, they have clinically terrible vein disease, and you took a bad measurement, didn't care, put it in the report, and you miss it. And don't piss off pre-cert, okay? Because they will get you if you don't have all the things, okay? Know your stuff. Know the measurements. Know what matters. And I'm going to end with this. This is a case study. I told you our first picture is always a Doppler. We let it run, and they're supposed to be angle corrected. This was a rule-out DVT in the left leg, and guess what? They let it run for about 2 seconds and did an augmentation. I can still see that that waveform is not normal, okay? They were diagnosed with a posterior tibial vein on the left side. Patient had a history of didyphus. Now, if this patient was a house, all my Atlanta people will know this would be a house in Buckhead or where, what you call it? Where do you live, Roswell? Marietta, Roswell, Sandy Springs. It would have been a $2 million home. This lady was like 37 years old, fit as a fiddle, didn't have a vein on her leg, just whatever. But she had a history of didyphus. Second and third follow-up, okay? One of those went weird, but guess what? They didn't do it again. They all augmented, okay? We had a come to Jesus meeting during a faculty meeting, okay? So fourth follow-up, guess what? I happened to do it. I'm the one who created the protocol. I like the protocol. So I measured, to me, it wasn't continuous, but it definitely was not phasic. I went up higher. You know, you can see both measurements. So you have 18.5, 25. There isn't iliac vein compression there, but I don't like the waveform. And then when I went down the leg, she also had continuous flow in the femoral and pop. So this was at the end of the day. My provider had seen this beautiful woman who did not look like a sick vein patient. And she was like, her daughter had a dance recital or something. It was 4:50, and she's like, is the DVT gone? And I'm like, yes, but. And she's like, slam the door. Okay? She really slammed the door on me. I was like, damn it, I'm one of the owners, you know. But I really don't act like that. But I scanned the patient, and I was scanning up the iliacs. It's continuous all the way, and all of a sudden I get in her mid-common iliac on that left side, and it's like a convergence of two Cs, red and blue. And I'm like, I've scanned so many iliacs, I've never seen flow divided like that, okay? And so I like sweeping through, I don't see anything, and I see this like 30 millimeter varicosity coming off this iliac and going into her pelvis. I still didn't know what I was seeing. I was just like, what the heck's going on? So it turns out she had a left-sided IVC, okay? So what a left-sided IVC is basically, instead of the left common iliac coursing under the artery, it actually courses over. I thought it was an ovarian vein connection, okay, because that's what it looked like, and it went right into the left renal vein. Now, the interesting thing about this patient is she did have the history of didyphus, which is 2 uteruses, 2 vaginas, 2 cervixes, and I was like, that's weird, you know. But she also only had 1 kidney. She only had a left kidney. So now we're talking about a different diagnosis. You have a patient with a left leg, innocent posterior tibial vein thrombus. However, the sonographer was able to detect that this patient had a left-sided IVC, that if she threw a pulmonary embolism, it's not going to her lung. It's going to her only working kidney. Okay, now you got this beautiful mansion that has a septic problem. Okay, and so I don't know what happened to the patient, what she ended up doing. If the treatment for this is an open surgery. And again, I think a lot of doctors would look at this patient and go, oh no, you're fine. But I was like, we need to get a confirmatory CT, and it was very impressive. I didn't include that, but again, there's different variations of duplicate or left-sided IVCs, anatomical variants. So in conclusion, patient had idiopathic left leg DVT, abnormal Doppler, duplicate IVC, important due to patient having 1 kidney, potential embolism. And with that, I'm done. Please join, as Josh mentioned, at the SVU annual conference. It's going to be in Nashville this year. And I'm also putting together a conference in Tulum, Mexico. If you like all-inclusive, premium drinks, and good ultrasound. There's actually 3 sessions. So there's maternal fetal medicine and GYN, so talk to your general ultrasound people. And then we also have an interventional session. Dr. Lasar and Jill and some others will be there. And then we have a vascular ultrasound session. So all 3 going on at the same time. March 19th through 23, and if you use code ESP, you get 25% off. Okay, thank y'all.
I have 90 slides before lunch starts, but I talk fast, so it's going to be just fine. I was tasked with valvular versus obstructive disease for the setting of chronic venous insufficiency, and this is not like Tennessee versus Georgia. Okay, so this is very different, and I hope to convince you of that. So Vic started about 8 years ago after I got a wild hair and said I need to do something different. Our main focus was really to develop a critical limb center to deal with some of the amputation problems that we had in our area, and then over time we did veins, and we became more of a focus on venous insufficiency. We're big on accreditation, so most of our testing is all IAC, but we also applied for the Vein Center accreditation, and we're one of 3 in the state of Tennessee, and also for deep venous accreditation, and we're one of 1 in Tennessee. So hopefully more centers will rise to the challenge of IAC and try to match the requirements. So chronic venous disease frequently is misdiagnosed. This is one of the problems that we have. People might have congestive heart failure. That's what their legs look like this. They're blamed on that. This might be lymphedema, and I've had patients that have been in compression sleeves for 10 years who have venous insufficiency and not lymphedema. And when you fix their venous disease, they have more of a normal life. It could be obesity, or the newer thing, lipedema, where it's painful obesity, but sometimes this is actually just plain old chronic venous insufficiency. Many of these patients come in with a diagnosis of restless leg, and it has to do with the pain syndromes that they have. But CVI is a common condition involving lower extremities with edema, trophic skin changes, discomfort secondary to venous hypertension due to reflux obstruction or both. So it's one of those 2 or possibly both. Each year, approximately 150,000 new patients are diagnosed with CVI, and it costs about $500 million to treat specifically these patients. If left untreated, then post-thrombotic syndrome and venous ulcers can form, and people have a hard time dealing with this. So I know veins is a passion. Brian clearly showed that was a passion of his. For the sonographers in the room, sometimes it is and sometimes it isn't, but it is incredibly difficult and it's incredibly prevalent. So we think that there's about 100 million Americans suffered with chronic venous disease. There's only 350 million Americans in America. And so a third of us, at least a third of the people in this room, probably have some form of venous insufficiency. Now, we think that the more higher leveled CVI is really down to about 6 to 7 million people in the U.S. 70% of those patients is primary CVI, whereas secondary CVI is associated with a DVT. We think about 1 out of 17% of men experience chronic venous, and about 1 in 40 women experience chronic venous insufficiency. And so it's more in men than women, although that's not what we typically think. Among patients, about 2.7% will develop venous ulcer, and many of those patients have recurrent disease. So what are the risk factors? It's advancing age, it's a history of DVT in the past, sedentary lifestyle, which can lead to this. Oral contraceptives are or hormone replacement therapy can lead to DVT formation. Leg injury, hypertension, and specifically family history. If it runs in families, especially if it's in both parents, there's about a 60-70% chance that you're going to have that problem too. The pathophysiology is for valve failure in CVI, we think is superficial valvular incompetence is due to weakened or abnormal shaped valves that can have widened diameters and they can fail. Deep venous dysfunction owing to previous DVT results from inflammation and then the valve scarring, adhesion, fibrosis within the lumen, and that can cause obstruction within the venous system. And when we have obstruction, then we start to have more pressure in the lower venous system, and valve failure can occur. Perforating valve failure can lead to higher pressure entering the superficial venous system from the calf muscle pump process. So you have to have normal valves, no obstruction, and a normal calf pump to actually have normal venous circulation. The pathophysiology of CVI is the resting venous pressure is the summation of the outflow obstruction, the capillary inflow, valve function, and muscle pump function. You have to have all three of these to actually equal the pressure that we're dealing with. Persistently elevated venous hydrostatic pressure can result in lower extremity pain, edema, venous microangiopathy. And then patients can develop permanent skin hyperpigmentation, lipodermatosclerosis, or ulcer formation in the advanced form. So what I'm trying to convince everybody is that it's not in Tennessee versus Georgia. It's not a valve issue versus an obstruction issue. It's a combination of both things. In that first slide, you see fairly normal function venous valves, then you see it abnormal. You can have high pressure at the lower leg. The middle picture shows red, but it really is the venous system, and you can see at the ankle level 90 millimeters of mercury. So if there is valvular dysfunction or central venous obstruction, you can have high pressures, almost systolic pressures at the ankle level, and you can develop the ulcer that forms here, which is not treatable until you treat the venous pressure. You must treat the pressure. And so we correlate the symptoms, the clinical symptoms, pain, heaviness, achiness, fatigue, edema, dilated veins, skin pigmentation, ulceration, the scarring of that dark scarring, that lipodermatosclerosis. And we recognize that there is the retrograde flow or the obstruction in that leg that causes venous valve failure and venous hypertension. So it's the venous hypertension that causes the symptoms. And that's what I want to drive together here. Because once we figure that out, that we can't get better until we actually fix the pressure, then we can actually start moving forward for patients. So how do we classify these patients? We tend to use the clinical classification system that's most common, the SEEP, and patients present fairly differently. In this patient, does this patient have venous disease? Anybody raise their hand, say yes? No takers? No? We got one. What do you see? Do you see a telangiectasia? So she had a small telangiectasia on her thigh, and so she does have venous insufficiency, and she would be a CEEP1 for that patient. Varicose veins, obvious, a little more obvious. If they're asymptomatic, no pain, no pressure, no heaviness, we watch them. That's what we tend to do. Symptomatic veins, we go after, and that's the majority of the venous insufficiency that we have in the country. Now, every one of these patients are going to have a superficial venous reflux exam. It does include deep at the femoral level and also in the deep system throughout the thigh. Now, once they're determined that they're superficial reflux only, then we consider different options for this. And we can use thermal, either laser or radiofrequency. You can use glue, medicated glue to close some of these superficial veins, or medicated foam. And I think they all have their place. And as Brian was giving his talk, he terrified me just a little bit with all the different variances. But again, my job is to fix the problem. I think as far as sonographers, you guys are the ones that can figure out the highways and the side roads and show me where the pitfalls are and what things to avoid. And so this is where we do work together. Now, when we're getting into SEEP3 with edema, we're starting to get into more of the advanced chronic venous insufficiency. SEEP4, you're getting the hyperpigmentation and the eczema. And then in the right panel, the lipodermatosclerosis. There's atrophy of the subcutaneous tissues. There's scarring of that vein. This is clearly more advanced disease. Now, this is actually a healed ulcer, or almost healed ulcer. We call that C5. And then C6 is a brand new active venous ulcer that we deal with. So in our patients, when they have more advanced disease, not only will we get the superficial testing, but we also look at the IVC and iliac veins and really start doing some of the measurements. Now, when we started doing this about 8 years ago, we started to understand a little bit more about looking for central venous obstruction and how that really plays a role in a lot of these patients and their symptoms. People with advanced severe pain, pressure, heaviness, achiness at the end of the day have to put their feet up at the end of the day. Their legs talk to them at nighttime when they finally get in bed. They have that restless leg condition. Makes us think more seriously along the line that this might be a central vein obstructive process. And so in the right panel, you see in the circle on the left common iliac vein, it measured 12.5. And the common femoral vein, it measured 13. That's the wrong way. You should start smaller at the groin and then get larger towards the heart. And so this is a sign that this is, at least to us, that this is something that is might need intervention, especially if someone has more of those clinical symptoms. So in the kind of early phase of our adaptation of our testing, we had a couple of things happen. One is we finally had technology to actually fix some of these problems. So we could actually, in phase A, start looking at some of these patients to see, do they have deep venous obstruction? And what we found was that we found quite a bit of it. And so we ultimately now have standardized not only just superficial testing, but also deep testing in the initial evaluation. And what we see is that about 30% of patients have deep venous obstruction. And many of these patients in the early phases were undergoing stent therapy for May-Thurner obstruction or possibly post-phlebitic to reconstruct this venous outflow. Many of the patients did well. And I would say 90+% of patients had significant symptomatic relief. So May-Thurner syndrome, let's just go through it just quickly, described by Dr. May and Dr. Thurner in the late 50s. They built their data off of other doctors, Dr. Cockett and others that described venous compression of that left iliac vein. And it's commonly done, compressed by the right common iliac artery. Oftentimes I see it's actually the distal aorta, and sometimes even bilateral iliac arteries are crossing over the iliac venous system. But what they pointed out was in their autopsy series, it's because most of these patients died from pulmonary embolus, was that they found luminal webs and membranes within the vein itself, synechiae. You'll see it, a rugged kind of appearance. And they also noted that there was a significant development of collateral circulation. Well, I think those are two important things clinically, because when you start to put it together, you start to be able to piece together what's obstructed and what's obstruction and what's reflux. This is the pelvic vascular anatomy. We can see that there's essentially 3 points of compression: that left common iliac vein compressed by the right common iliac artery. The internal iliac arteries coming across can compress the external. And it's either the recurrent circumflex branches from the arteries compressing the femoral, or it's the inguinal ligament. I can't really determine which way it is, but it's some kind of compression at that point as well. If you fix 2 of those, you still have a problem. You have to fix all 3 if the patient presents with all 3. So we can do, obviously you can see on ultrasound, the compression. We can order some of the testing, the CTA, 3D reconstructions. You can see in that right panel the compression along that common iliac vein. And we treat these often with bilateral iliac venous stenting. Now, most of the stents now are iliofemoral approved, but what we find in these patients is that the compression is often high. So it's not uncommon to see a double lumen kind of stent in our patients. When it comes to pelvic congestion, we can still have iliac vein compression. Patients have pressure, heaviness, achiness in the pelvis, worse during their menstrual cycle. It can be simply by standing that they get the discomfort. And on testing, it's the iliac vein that's compressed, causing internal iliac vein reflux through the small veins that range around the ovaries and the uterus. You can see that on the bottom panel, the vascularity associated in that adnexal area, in the periuterine area. Now, sometimes it's compression of the left renal vein with that superior mesenteric artery coming across. And if you have compression at that level, you're going to have more pressure along the escape vessels, which is the ovarian vein, and you can start to have valve failure and lead to, again, pressurization of those adnexal vessels. Sometimes you have both, and you have options then of treating that. But this is an example of that compression of the left renal vein on ultrasound. You can see the superior mesenteric artery directly over top of the aorta, and the vein smashed in between. Now, if the patient starts having problems with hematuria or flank pain, this could be nutcracker. That could be the ultimate answer for that. But a lot of times we're seeing is just ovarian vein reflux. Our criteria is greater than 6 millimeters of diameter with specific showing of reflux, and most insurances will approve that. You can do CT imaging or MR imaging to really help further define, but this is a very common process that we're seeing for these patients. Treatment is catheterization and embolization if it's specifically and solely related to the ovarian vein reflux. Now, if it is associated with the May-Thurner obstruction, then stent reconstruction is preferable. Sometimes in patients, if I had both problems, we tend to fix the May-Thurner obstruction with a stent. 2/3 of the time, we will have resolution of the pelvic pain, and then about 1/3 of the time, the patients I explain to them is that they may have to have that ovarian vein embolized as well. Now, patients also present with acute iliofemoral DVT, and this patient has severe swelling, history of VTE, changes. This was associated with a change in hormone therapy and developed significant acute iliofemoral DVT, seen on imaging here. Now, fortunately, we have newer techniques to actually remove a lot of this clot and debris. Anticoagulation isn't the only thing that we can do. And hey, Frank, I'm going to miss it. Sorry, would you just let Will know it's going to be about another 15 minutes? Thank you. We have a live case following this, and I want to just make sure the timing's right. The many devices now to actually remove clot and open up the venous system, but oftentimes there are damaged valves. We have reflux disease, and that can lead into patients that develop a wound or a sore. Now, this patient had a year's worth of venous insufficiency, ultimately developed a sore. This is when we saw him. We started probably about 8 years ago with Metahoney and Luxtra and wrappings. And month 2, doing the same thing. Month 3, we added bag balm and a couple other different compressions. Then we got the ultrasound and found that there was deep reflux, evidence of compression in that left common iliac vein. And then by month 4, we're still wrapping. By month 5, we're treating the superficial venous system now that we have approvals from insurances. And ultimately went to a venogram with a stent to reconstruct his iliac vein, which had about a 70% lesion in that vein. And month 6, we had an epifix, almost finished, and by 6 months and 2 weeks, we finally got it closed. So who thinks that was successful? Raise a hand. Who thinks that's successful? Successful. What if that was your leg? If that was your leg, can you imagine dealing with this for 6 months? And I think that there's much more understanding now of what's going on with this. I think that early ultrasound testing should drive the care for this patient. And this is not a wound problem. This is a pressure problem. They happen to have a wound, but this is a pressure problem. And until you fix that pressure, after we fix the pressure with the superficial reflux reconstruction and the deep reconstruction, within a month and a half, his wound healed. But he suffered for 4.5 months while we were doing wound care. So there's a disconnect. This isn't a wound problem, this is a pressure problem. And so until we fix the pressure problem, the patients won't heal. So there has been a revolution in technology with the newer stent technology. This allows us to fix these problems that we didn't have before. And the most common presentation that we have are nivels. Has anybody heard of a nivel before? Raise a hand, nivel. A couple people, one person. So it's a non-thrombotic iliac vein lesion. So what does that mean? That means they didn't have a DVT, a PE. They are presenting with a compression of that left common iliac vein with a symptom. And the symptom is pain, pressure, heaviness, achiness, swelling. So if you find unilateral swelling, then that would be a sign that there might be obstruction. And so those are the clinical things that we get to order the ultrasound testing and start the process. Now, what we find is that this is often in both sides. Both limbs are usually affected. Both sexes are infected, and it can affect all age groups, young to old. And it's not just a left leg female, in their mid-30s that get May-Thurner syndrome. This is a very common process. We think 30% of symptomatic patients have some kind of obstruction in the process. So who do we treat? Who do we want to do a venogram on and stent? Well, if they have that severe categories of CVI, edema, C3 through C6, we definitely want to start looking at testing. The time frame of A was reactionary. We would kind of get that history and order the test. Now we're doing the testing universally, and so we think that the incidence of May-Thurner is about 30%. Does that mean 30% of patients need a stent? I don't think so, because we're dealing with young people that are going to have a stent the rest of their life. So we want to use that technology for the patients that really need it. So we looked at our kind of referral history over the last 4 years, and in red's the arterial referrals, and blue is the venous referrals. You can see in blue over time it is slightly increasing. Arterial gets to be about 27 to 30% of our business, of what we do. And then the deep venous system actually starts to fall off. And right at this point, when we just look at the vein system, we see a rise in that light blue, and that's because of we decided to treat patients more specifically, maybe more multiple procedures to dealing with the problems and getting people out quicker. But in that first section, by changing what we're doing, by treating the superficial venous system first, we've driven down the need for a stent into that 15% of the time instead of 30%. As far as the lab, what does that mean? It means that you do 3 times as much ultrasound than what you did before. There's a lot related to the procedures. There's a lot in pre and post-op follow-up, but volume has increased. And as a person who runs a critical limb center, I need that ultrasound time to take care of arterial patients. So we've had to expand our staff and redevelop and deploy additional rooms to handle that load. So what is the optimal endovascular reconstruction? When we look at the two groups, male, about a third of the time we're reconstructing, female, 2/3 of the patients. If we looked at 1,100 catheterizations for venous stenting, what we found was that one stent was used about 28% of the time. 44% of the time had multiple stents, and on IVUS, where we determine whether if they are obstructed or not, only about a third of those patients did not have obstruction, so they obviously didn't get a stent. They don't need that. But essentially what that means is about 60% of stents were bilateral, because it is an iliocaval obstruction, not necessarily a left common iliac vein obstruction. And so we think that technical repair requires kissing stents in about 60% of patients. And then I'll hit this last patient with you, 64-year-old white male. He reports claudication, increased swelling, weeping of fluid at the ankle, discoloration of the toes and foot. He's had a history of DVT, PE, and chronic anticoagulation, smoker, and then telangiectasias, hemosiderin staining of the left forefoot. So he was the one that had the stenosis at the left common iliac vein. You can see in the green is the normal size of the vessel. The light blue teal is where the area of compression is. We think that's about 70%. The arrow points that says 80. That was my ballpark on angiogram, or venogram, I should say. And he also had obstruction of the left or the right side as well. And so he did have the tip of that blue or the green arrow is the cable bifurcation. And so we do have stents that are slightly up into the cable on both sides. And then you get your double barrel kind of outflow image. Oftentimes patients are improved. This patient came back, had no further complaints, no swelling, no pain, no weeping of fluid, walking's improved. Why is walking improved? Because you can have venous return to the heart. If you can't have venous return to the heart, you can't walk, you can't exercise. Patients complain of that. He's on chronic Xarelto for at least 3 months. And we think that after these type of procedures, their patients are on dual antiplatelet therapy or systemic anticoagulation for at least 6 months, aspirin for life afterwards, surveillance duplex ultrasound for life afterwards. These stents have only been around for 7-8 years, and committing somebody to a stent that's a younger person, we don't know what 30, 40, 50 years could be. So we do have to feel responsible for surveilling these patients. As far as central venous stenting, symptomatic May-Thurner syndrome is prevalent in symptomatic venous disease in the rate between 15 and 30% of patients. Bilateral symptoms are common, affect both male and female, and present at all ages. And then endovascular stent repair requires iliocaval kissing double barrel technique in about 60% of patients. This technique seems to be durable with few complications and excellent symptomatic relief. I tell patients post-operatively that, or pre-operatively, that I'd expect about 90% of patients having significant relief from their symptoms once we've addressed the problem. So at this point, I'm going to conclude. I'm going to ask if there's any specific questions. And Brian, are you still in the audience? You are. We are relatively on time. Let's see where we are. We do have a live case that's going to be coming on with Dr. Harris at Vic currently, and I don't want to delay that any longer. Do you guys you ready for that? Thank you. All right, so let's go ahead and do that, and then lunch is going to be provided out here. It's going to be on this side. We're going to be speaking. This live case is going for the next 45 minutes. Brian, maybe we can answer questions independently afterwards. If you guys have specific questions, come up and find us. And if Dr. Harris gets done quickly, then maybe we'll answer some more questions at that point. So I'm going to let Dr. Harris introduce this next case, and we're going to go from there.
Chris, we on?
We're on. Yep. We're on, Will.
Hi guys, how are you? Welcome to Chattanooga, Tennessee. Thanks to BD for sponsoring this and Emmertech for helping us out with everything. Tate is here in the room. He's helping us out with the audio visuals and broadcasting us live into the Marriott. And I've got a great team here today. I've got Krista manning the computer as our nurse. And then Sophia's right here next to me, and Aaron and Holly over there, and Christine providing anesthesia. So we've got a great team here and hope to bring you a good case. While we were waiting with a little bit of a delay, I went ahead and got access. But we have a really pleasant 48-year-old female. I think Tate has the slide deck up, who has pretty significant swelling, cramping, fatigue, and pain. She's very active, was walking up to 5 miles a day, recently moved here from California. She is a Navy veteran, and she's become so disabled with the swelling, the achiness, the cramping, and the pain that it inhibits her from walking much more than a mile every single day. And she has fatigue and swelling that's pretty horrible towards the end of the day. We've done a venous reflex ultrasound on her as part of our standard workup, and I believe that was just recently discussed in your ultrasound session today. So, Kate, can you? I'm not sure where we are in which slide it is. Okay, that slide is up right now, and you can see that her venous reflex ultrasound was pretty underwhelming for the kind of symptoms that you would expect with her. So she did have some fairly larger greater saphenous veins proximally, but very little reflux, and wouldn't really characterize it as what I would expect for her symptomology. So moving forward, we did measurements of her inferior vena cava and her iliac system, and that was significantly more impressive. She had significant iliac compression. And so we counseled her and talked to her about the merits of intervention versus conservative measurements, non-operative interventions, and she elected to proceed and wanted to go ahead and have us do a venogram and take a look up top. So feel free to stop me with any questions. We got access in the common femoral veins bilaterally. We have 2 10 French sheaths here. And you can see our ultrasound on the left, and the ultrasound is the artery, and the right is the common femoral vein. All of our access is ultrasound guided. Sometimes I will stick the greater saphenous vein for some of these accesses. You can see the saphenous vein coming in here, but I've got the sheath going into the common femoral vein on the left side. Again, we've got 2 10 French sheaths in, and we've done, and we have 2 Benson wires, and we're going to do bilateral venograms right now. Kind of take a look and see what you see.
Good morning, Dr. Harris. I just wanted to let everybody who is observing know that you are able to move the overlays around, and then at the bottom right-hand corner is a blue box that will allow you to resize them so that you can enlarge the fluoro screens, the IVUS image, and anything else that may be pertinent during the procedure.
Yep. Thank you, Robert. All right, digital subtraction angiography. See how coordinated I am to run this. Okay, you can see the veins running up, and it appears that it looks, and a venogram is a 2D representation of a 3D view, but it looks on the right side, the right kind of distal common iliac vein is fairly small, is a little bit smaller, and then you see a very widened out left common iliac vein, and you can actually see, Aaron, or Holly, can you draw the collateral that you can see coming off shooting north? Can you point that out with an arrow? And you can faintly see that collateral shooting north, and that's something that you can sometimes see with significant iliac venous compression, is the formation of collaterals taking up flow to return blood flow back up to the heart with iliac vein compression. But it looks like the vein's wide open in a situation like this, but stay tuned. We'll prove that it is not. All right, so now we're going to go in with our intravascular ultrasound. Intravascular ultrasound is really gold standard for diagnosing and management of deep venous disease. I think that doing venograms and interventions without using IVUS is a criminal act. That should be done. Yes. Yes.
Mr. Chris, do you have the IVUS slaved to the monitors?
Yes.
So we're not seeing IVUS, which would be really, I'm sure all the ultrasound techs would love to see that. And maybe we're getting that organized.
All right. I think we got
There
a
it
heartbeat.
is. There it is. Thank you, sir.
Congratulations, I'm not pregnant. That's one thing. So, all right, we've got the IVUS catheter inside the vein right now. This is on the right side. Spot Holly, please. So we're going up on the right side. Give a little more slack, would you?
Where are you
See
at?
a little bit narrowed right here, Spot. And we're up very proximal, so the vein gets pretty significantly narrowed. You can see a fair amount of pulsatility coming from it. That's from compression from the surrounding artery. You're probably near the aorta and the right common iliac right there. You can see the wire on the other side coming in. And the inferior vena cava itself is somewhat compressed as well. If we took this probe way up, you can see the inferior vena cava kind of widens out and becomes significantly more open.
It looks
we'll do a pull back record.
It looks a little underperfused. That vena cava looks to be pretty small.
Is very underperfused. And it could be because she's dry, but I think she also has pretty substantial disease. So we're going to come back right here. I could actually feel like give in the ultrasound probe as it came by this one segment, and then here, the external iliac, it gets pretty small for the size of the lady she is, and then it widens out and kind of opens up again. And you see how much wider it is down here in the distal external iliac as opposed in the common iliac. And that's not natural. Stop.
Will, what does the femoral vein look like at that level? I'm just curious to see the diameter on IVUS.
Well, I stuck to the common femoral vein, but it looked fairly wide open on ultrasound when I accessed it. So we'll go in now and run into the left side. So we're going up with ultrasound up into the inferior vena cava again. And I don't know if you can track both our x-ray, but look, I'm getting a fair amount of resistance, and then boom. As you can see, there's fairly significant compression. So let me rotate the IVUS so you have more of an anatomical view. Mm-hmm. As you can see, the iliac vein, that's where the catheter is in, and it's almost occlusive. Sitting right on top of the iliac vein is the right common iliac artery.
And so the artery at the top, the spine below, and the vein in the middle.
Correct. It's a pancake. And then it opens up and we're back in the inferior vena cava. So kind of a classic picture. Record.
Were her symptoms mostly left-sided or bilateral?
Bilateral, interestingly enough, somewhat worse on the right. Slightly worse on the right, but significantly bilateral fatigue, bilateral pain, cramping, swelling. Mm-hmm. Stop recording. So, live on IVUS. What I do in a situation like this, especially since I think she has concomitant right-sided disease. Left-sided disease is much more prominent. There's right-sided disease as well. Spot. So I mark kind of a normal point of the inferior vena cava. Thank you. So we're just going to make a mark there, and that's going to be a kind of a general landing zone. I'll go up and confirm that, putting in my IVUS up the right side to make sure I agree with that. I got a couple 16-1, probably 16-160 for the right and 16-140 for the left. Or 16 for the right and a 16-120 for the left.
So you're picking stent sized based off of.
Yes, sir.
Based off of what?
I'll go pretty long on her on the right side spot, just because I really want to get down into that external iliac because I think that's pretty significant disease. It narrowed to spot. And so I think that's a good place to potentially land my stents right here. These markers that you can see on fluoroscopy are 1 centimeter markers. So a 16-160 should get us to where we need to go. Record. And I like my marker placement. Perfect. Okay, stop recording. All right, so we'll put up both stents at once. Beautiful. We're using BD Venovo stents in this instance. We're using a 16-160 on the right-hand side and a 16-120 on the left-hand side. And for an average-sized female, these are kind of standard diameters that I'll use for the venous system. I definitely don't want to undersize the stent. That could have somewhat dire consequences. Which size is it? Perfect.
So the typical range of stent size for most patients is somewhere between 14 millimeter diameter to 18 millimeter diameter. A man with large veins, you might get 18 to 20, but that's generally like the upper side. I would say most patients, at least in my experience, about 80 to 90% somewhere have about a 16 millimeter common iliac vein, and it will accept that level of stent.
And BD has sizes all the way up to 20 and stents as short as 40 and all the way up to 160 in length. Perfect. Fine. Can I get a couple of 1480 balloons, please? And so I'll put the two stents up and I'll put them up kind of parallel next to each other. This is how I standardly deploy two stents at once. I'm not coordinated enough to deploy both of them at the same time and think that I'm going to do well. And so, live on X-ray. So I'll start off with one a little bit higher than the other, and then I'm going to start off on the right side. Just a little bit of a straighter shot. I'm going to start a little bit higher than my markers. Fine with me. And work my stent all the way down deep. The Venovo has a triaxial delivery system, so I can deliver it very precisely. With these. Holly, can you move south just a skosh? Skosh is a medical term that we use with routine. Why? And that stent's released very nicely, so Sophia's going to walk it off for me. Okay, can you go back up a little bit, Holly, and give me a magnification on that? Here, I can move.
So one of the objectives while he's finishing the second deployment is to cover, to expand, place a stent that will open up all areas of compression. We don't want to leave any compression behind, no compression behind. And we also use a longer stent because we technically don't want that stent to move. That stent will stay in place the longer it is versus if we use a real short segment.
Yeah, I really want to make sure that I land it into healthy vein, correct? Non-compressed vein. And so what I do here is I'm putting up a balloon and I'm having this serve as kind of a buffer. So it's into the inferior vena cava, and this is a 14 millimeter balloon. Now that I've done this, I can make sure that my other stent that I'm about to deploy doesn't collapse the stent that I already have open. So I'm bringing this stent down. Now the BD Venovos have kind of a flared proximal portion to it, which we've learned to use to our advantage in these situations. And so that's perfect. The balloon's doing exactly what I want it to do. And keeping that part open. We land them pretty close to each other at the top, so there's no real overlap. Come off your zoom, please. And I like that right there. And so we're going to walk that off and go in with a second balloon. Now, I often get the question from patients, can we just balloon it? Would that be adequate? In a situation with non-thrombotic venous obstruction, a balloon doesn't cut it because you'll instantly collapse there's no real benefit to only balloon. There's not enough radial force. It doesn't have any long-term effect to the vein. As a matter of fact, it probably damages the vein more than it helps the situation. So these stents are nitinol based. You know, they have a fair amount of radial force. They have a significant amount of radial force, and they're indicated for use and approved by the FDA for this exact purpose, placing it in the iliacaval venous system. Or correction, I'm sorry, the iliofemoral venous system.
So that is.
So we've got two balloons going up here, and we'll just bring them down at the same time. 1, 2, 3. Sorry, Chris, I cut you off. What'd you say?
No, I think that's a good distinction. You know, the technology was designed and built for iliofemoral stenting, but what we find is that you have to place this beyond the level of obstruction, or you still have obstruction, and oftentimes it's at the distal vena cava. So I think that you know, industry and regulators need to catch up to really where we need to be to actually treat this condition.
I'm pretty happy with the way that both of those stents deployed. Now we'll take the completion venogram. All right, DSN. And as you can see, the flow through there is brisk. And I'm pretty happy with that.
Looks
that
like
collateral that you see on the right side will probably go away pretty soon, now that we've relieved the obstruction.
yeah, vena
Or it'll
cava.
completely collapse. It may not go away, but it'll almost completely collapse. We have the intravascular ultrasound in the right side, and as you can see, this inferior vena cava is a whole lot bigger now that we've put the stents in. Record.
So that's one of the common questions I ask patients when they have evidence of venous obstruction like this is, do you have difficulty walking? Do they get short of breath? And it's a fairly common thing that we'll find. Especially,
They're actually starting to see some more relation to POTS, postural orthostatic hypotension related to venous obstructive disease. I think you're going to start to see more data come out as far as that. Now we've got the IVUS up the left side. And you see the stent coming through right there. I went through a strut. Sorry about that. Block.
yep.
I'm still going through a strut.
Looks good, Will, though. I mean, it's still widely open.
It does.
What was it? What was the percent stenosis calculated in that?
On the left side, it was 90%. On the right side, it was about 60. Record. And we look at healthy vein diameter and compare it to unhealthy vein diameter, right? And so that's how we do our diameter calculation. Stop recording. That's pretty fantastic right there. I'm pretty happy.
That's awesome.
So what my protocol is we'll typically keep her on either systemic anticoagulation, or I do a lot of times dual antiplatelet for the NIVL patients for approximately 6 months, and then I recommend a baby aspirin for the rest of their life. You know, there's no clear guidelines as far as these go. If the patient is post-thrombotic, then we'll keep them on, you know, systemic anticoagulation for a fair amount of time, you know, but I know people who do these and only keep them on a baby aspirin, and they seem to be fine too. So, and I know people who do full systemic anticoagulation for a year. So I don't think there's a right answer as far as this goes, or a wrong answer. We're trying to experiment for pain control in these patients. We're sending them home on Robaxin, muscle relaxant. This was Chris's idea, and after pulling some patients, it's been a really great idea and a great way of treating these patients. The patients will have some musculoskeletal pain, flank pain after putting these, because it irritates the nerves on the psoas and things like that. So, but really, I think really solid result. I'm very pleased. Any questions, Chris?
Yeah, I'm just, the audience is grabbing some lunch. Is there any actually questions about the technique so far or any issues? Looks like they're enthralled with lunch and the video. So I think we're going to step away from here at this point. So at this point, the successful operation, pretty happy with it?
Very, very.
And I think that took you all of 20 minutes to do it.
Yeah.
So I think
Enough time to go get lunch.
So there's a lot of thought process that goes behind deciding who is a candidate for this type of procedure. It's proved by intravascular ultrasound as to diameter reduction. Will, one quick question: what's like the minimum diameter reduction that you would treat in a patient like this with symptoms as severe as she's had?
60% is the gold standard in the United States. That's what the data is based off of and everything else. So typically we shoot for diameter reduction around 60%.
Fair enough. Okay, so the question was, how are you going to close?
How am I going to close? So there are a lot of expensive ways to close, but I'm just going to pull the sheaths out and put a little suture in it. And it works great.
Yep.
Little figure of 8. Remember, it's venous, so it's a low pressure system. So, for 10 French sheaths, it works well.
Yep, and we often just support that with a little pressure dressing. No, we tape it on, and we leave it on for 24 hours. Sutures is a dissolving suture, so after 2 weeks it dissolves and comes out. So they just shower right over top of that.
Correct, it usually just falls out on its own.
Yeah. I'd say most people have, I always tell most of my patients, at least 3 days of pain in that low back, low pelvis. It can be longer. I've seen it 6 days. I've seen it a couple patients with severe obstruction up to a month. But most of the time it's tolerated fairly well, and people can start to feel better fairly quickly.
And I think I used to see more flank pain and things like that persisted long terms, where we were using different types of stents that weren't necessarily indicated for this sort of thing, and using the wrong size of stents on these patients. And so I think with the advent of the newer technology stents like Venovo and appropriate sizing, I don't see as much pain-related issues long term as we used to.
Will, thank you very much. We appreciate all your efforts, and thank your patient for us.
Hey guys, enjoy the conference, and I'll see you all tomorrow.
All right, excellent. Thank you so much. Signing off.
Cheers. Thanks, Robert and BD.